Okay. Thank you for joining us today, everyone. Welcome to MVC's Rural Health Work Group presentation. My name is Rachel, and I'm one of the Site Engagement Coordinators with MVC. It's my pleasure to be facilitating the work group for you today. Just a few housekeeping items to remember. We do record these presentations, and the slides and recording will be shared with participants following the work group via email. Please also remember to mute your microphone if you're not, part of like a discussion or question answer time. This helps reduce any background noise that we might have. And then if you have any questions throughout the presentation, you can feel free to put them in the chat, and we'll be going through those at the end of the presentation during our discussion time. Just a quick reminder for our P4P credit seeking sites. We do ask that you have active participation throughout the work group. And this includes answering any discussion questions and also participating in those discussions that occur. And at the end of the presentation, we will be posting the post-work group survey. Completion of the survey is required to receive the engagement points for your P4P credit. We also encourage anyone to fill out the work group survey just so we can get some feedback and keep improving our processes as we go. Today we'll have a presentation from Scheurer Health about their SEP 1 compliance process improvement initiative. Following that, we'll have our discussion question and answer time, and then we'll have some MVC upcoming events and updates to go over. Today's presenter is Victoria Durr. She graduated from Davenport University in 2017 with a bachelor's degree in nursing. She spent the bulk of her career in rural emergency departments throughout the Thumb area of Michigan before beginning her current role as infection prevention coordinator at Scheurer Hospital in September of 2024. So now I'm going to hand off the reins to Victoria to continue with your presentation.
Great, thanks. So first of all, I want to start off just by thanking everybody for joining today, thanking MVC for allowing me to present on our process improvement for SEP 1 compliance. Being a very small hospital, I think we face some unique challenges, and other rural hospitals may be facing the same issues. Next slide, please. So, like Rachel said in my introduction, I graduated from Davenport University in 2017. Following nursing school, I spent several years working in emergency departments throughout the Thumb, so I have a very invested interest in the care of this community. In September 2024, it was time to serve the community in a different way, and that's when I joined Scheurer Hospital as their infection prevention coordinator. I really enjoyed my new role, gaining a different perspective on the care we provide, and I've learned a lot of the why behind the care that we have provided over my career. A little background about Scheurer Hospital for those of you who may not be familiar. We are a 25-bed facility on the west side of the Thumb. We have approximately 500 ED visits monthly and 200 inpatient days monthly. We have a mixture of inpatient, observation stays, hospice admits, and swing bed stays. We do have lab, CT, X-ray, physical therapy, and a fully operational OR with several specialties. These may seem like basic necessities at other hospitals, but not all rural facilities, especially those in the Thumb, have these available to them. So we are very fortunate. And next slide, please. So where we started back in September of 2024. So now that you know a little bit of the background, I think that some of the challenges that we faced might make a little bit more sense. I started reviewing ED and acute care admissions with a coded diagnosis of septic blank, sepsis caused by blank, etc. when I began my new role. Currently, we only have data beginning in July 2024 through May 2025, just because that's how far retroactively I looked back. When I was reviewing charts, I could see that the care we were providing was really great. We had all of the things that we needed. We just weren't doing them in the correct order, or the timing was off even by a little bit. In talking with our ED leader and our acute care leader and our nursing staff, I found they had very limited knowledge of SEP 1 and the 3 and 6 hour bundle requirements. And why would they know that? They're the ones that are focusing on providing the care in the moment. They're not worrying about the chart audits at the end. Through these discussions, I found that staff was a little unclear on the vital sign parameters that would meet for SIRS, such as a heart rate greater than 90. They always assumed it was greater than 100. They didn't realize that a repeat lactic acid would need to be drawn if the initial was greater than 2. They assumed that if fluids were administered and the patient was showing improvement, then it wasn't really needed. It could just be done with routine lab work. They also didn't really realize that blood cultures were even part of the equation. They kind of thought that was physician preference. And one of the biggest ones is that they believed every patient with a diagnosis of sepsis needed that 30 milliliter per kilogram bolus. They didn't realize that it was dependent on different clinical criteria like blood pressure, or that it could be deferred based on comorbid conditions as long as the physician was providing adequate documentation. Next slide, please. So after getting all of that information, I realized we had to start at the very base of step 1. I took a step back and identified all of the challenges that we faced, which were pretty numerous. To start, we only have one ED physician on staff at any given time, with 2 to 3 RNs and 1 PCT. We have 5 patient treatment rooms and 1 hall bed, which seems like adequate space and nursing staff most of the time given our volume. However, if that ED physician is busy seeing all of the patients with their varying acuity, we might fall behind on orders being placed for the patients who we are ruling out sepsis. We also have a limited availability to admit patients to our facility just because of the lack of the specialty care some of them need. From the data I have, 58% of patients with severe sepsis or septic shock are transferred out of our facility. The largest challenge that our data faces is our ED sepsis census. In any given month, we may only have 5 to 15 patients with a sepsis diagnosis, and after chart review, only 1 to 10 of those might meet criteria for severe sepsis or septic shock. It severely skews our compliance numbers and means that our ED staff is not regularly implementing the 3 and 6 hour SEP 1 bundles. We don't have hospitalists here. Our patients from the ED generally get admitted to their primary care provider, which is great for continuity of care. However, any orders our ED physician puts in get canceled upon admission to the acute care unit because our ED physician does not have admitting privileges here. That's resulted in antibiotic orders, fluid orders, and then most frequently, our repeat lactic acid orders getting canceled upon admission. SEP 1 relevancy is also very low for our nursing staff. We don't get to practice compliance very often, so it's not on the forefront of everyone's mind. And in the past, they tried to use best practice advisories, but they came up so frequently and in incidences where sepsis was not even a concern that they were easily ignored and just clicked through. Next slide, please. So I knew that we faced a lot of challenges. They'd need to be addressed one by one. I started meeting again with acute care and ED leaders, and we discussed SEP 1 in entirety. They relayed pertinent information back to their staff, particularly just by bringing up sepsis as a focus. I worked with the department leaders then to come up with a sepsis worksheet for nursing staff. It's of course not required, it's not considered orders, it's just supposed to be a guide that condenses SEP 1 and provides real-time education to nursing staff. We also identified that our phlebotomists draw the majority of our blood cultures. When lab gets busy, because they also perform the outpatient draws on acute care, and then draws in ER, that may get delayed. Our ED leader and our lab leader decided expediting blood culture draws with a phone call to the lab would resolve that. pretty much completely. I do my best also to keep an eye on the ER census and provide real-time chart audits, but that's not always possible. In rural healthcare, we all wear many hats, so sometimes my time does get divided differently. And we also have so few cases that the likelihood of a septic patient showing up when I'm here is very rare. Next slide, please. This is the nursing worksheet that I came up with the help of ED and acute care leaders. We were able to come up with something that makes sense to their departments and the situations that they see. It provides a stepwise approach to determining if someone meets clinical criteria for severe sepsis or septic shock and the direction that care may be heading. Then it equips the nurse with the ability to make care suggestions to the physicians, whether that be the emergency room physician or they need to call the patient's admitting physician. It looks wordy, and it is, but we very rarely make it to the last 1/3 of the worksheet. And the idea was just to summarize SEP 1 since the guidelines themselves are very lengthy. Like I said before, it's not required that our nurses use this, but I didn't want them to feel like I was adding more work and more paperwork to their already high workload. It had been discussed with our ED leader that if our compliance did fall, then it may become more of a required piece of documentation, not part of the patient chart, but just documentation for the quality side of things. One important thing to note about this is that when the SEP1 worksheet has been used and our nursing staff does utilize it pretty frequently, they have been 100% compliant in those cases. Next slide, please. So in addition to the proactive tools that we came up with, I also provide individual clinician feedback to physicians and nurses monthly. It's primarily done through our ED leader as she has amazing rapport with her nursing staff and physician staff. I make sure to take note of deficiencies, but also take note of really good documentation or marked improvement that I see, and make sure that she shares that with that staff member. From the nursing side of things, I have seen huge improvements in their documentation, particularly when they're noticing clinical criteria or documenting when a physician is contacted for orders, like repeat lactic orders, blood culture orders, etc. From the physician feedback, I found that physicians did have a little bit of confusion regarding the reassessment needed after fluid administration in septic shock. Most of the time, they would address a couple of clinical criteria like heart rate or blood pressure, but they wouldn't satisfy all the requirements for that reassessment. Through the help of the ED leader and the physicians, we were able to create a guide for the ED physicians to reference. And it's important to note that, like nursing staff, they also weren't primarily concerned about compliance with SEP 1 or staying up to date on all the intricacies of SEP 1. Talking to physicians as well showed us that we actually had 2 order sets for patients that we were seeing to rule out sepsis. One of them had no blood cultures included in it, and that was the order set that showed up first on the list, and so it was most often chosen. So it did rely on manual addition of blood cultures to that order set. Next slide, please. Unlike the nursing worksheet, this is just a summary of the important information from SEP 1 that physicians need to know. It's intended to be a quick reference, but I use the term quick very loosely because it still ended up being very wordy. Like I said, the heart rate and blood pressure were typically addressed when a physician was documenting a reassessment after fluid administration, but other elements were usually missing. So it's just intended to remind the physicians of all the elements they need to address if they choose to go that route with their documentation. Next slide, please. So this is a breakdown of our areas of non-compliance over the past 3 quarters. Data from Q2 2025 is not yet complete, so it's not demonstrated on this slide. In quarter 3, 2024, our most frequently missed area was antibiotic administration outside of the 3-hour window from time zero. We talked a lot about this with our staff and did a really great job at correcting that by quarter 4, 2024. However, we got so quick at administering antibiotics that now we were giving antibiotics well before blood cultures were even drawn. So that kind of became a focus after quarter 4. By quarter 1, 2025, most of our new processes were implemented and we had an even breakdown on our issues of noncompliance. I like to break down data into small chunks for our clinical areas, especially with sepsis care, so it doesn't seem overwhelming and we have one direct area to focus on. With the even split of quarter 1, 2025, we continue to work on drawing our blood cultures in a timely manner and before our antibiotic administration. Next slide, please. This graph highlights our running total for area of noncompliance. I keep this graph going and present on it quarterly at my infection prevention meeting. And this has helped me tailor our focus, which is why we continue to focus on correct timing of our blood culture draws. Next slide, please. So a little bit more about how we faced a lot of the challenges that we had identified. There continues to be items that we've worked on in the very recent past, and all items on this slide have been implemented since the beginning of 2025. In June, we created an escape room for our annual nursing competencies. Many clinical areas were addressed, including cardiac care, chest tube maintenance, patient safety, and sepsis. I created a fake patient chart of a patient diagnosed with cellulitis with severe sepsis. The chart had to be thoroughly read to extract information that would then be used to move on to the next part of the escape room. Nurses had to recognize the signs and symptoms of sepsis and calculate a sepsis bolus. The communication that occurred between nurses was great, and I absolutely loved seeing them discuss all the things that we've talked so thoroughly about for the past several months. I'm happy to share more details of the escape room if anyone is interested, and we did get great reviews and even some requests to do something similar next year, which I felt like was a huge win for annual nursing education. Another item I began last month is sepsis orientation with our new hire ED and acute care nurses. This is possible for me to do because we don't have a huge volume of nursing staff or a high turnover rate. I introduced SEP 1 and the sepsis nursing worksheet and explained that while I'm here, I'm available to look over a chart if it's needed. I don't want any of the nursing staff to feel burdened by this or like I'm adding a bunch of things, so I didn't want to rely on whoever was providing orientation to these nurses to have to also address SEP 1, the nursing worksheet, because that's kind of my baby. I got really great feedback on that, and I also think that it helped break down the wall between clinical staff and the quality department and opened up a nice line of communication. Our patient safety coordinator and our nurse educator are also working toward a standardized nurse handoff report so that critical information, such as those repeat lactic acid draws, don't get missed. That hopefully will assist with the issue of this getting unintentionally missed when a patient transitions from ED to acute care. I also started tracking length of stay, mortality, and sepsis-related readmissions or repeat visits to the ER. That is mostly possible because of Epic. I only look at patients' inpatient or observation stays. No days spent in swing bed or rehab are included. And if I'm unable to find their length of stay, they just are exempt from the data. I hoped that the data directly from the patients that we care for would show why evidence-based sepsis care is so important, increasing that relevancy to staff. Next slide, please. As you can see, through 3/4 of data, our patients consistently had a shorter length of stay if we provided care that was consistent with SEP1. Not only that, their length of stay stayed consistent right around 6 days. This is another measure that I report on at my quarterly infection prevention meetings, and I share it with our department leaders and staff to increase that relevancy amongst our clinical providers and show why compliance truly is important. Next slide, thank you. I track compliance with SEP1 monthly and also report on this quarterly at my infection prevention meeting. As you can see, we had an extremely dramatic drop from 100% to 0% between July and August. I think this best highlights the volatile nature of our data. In August, we only had 2 cases, and we were unfortunately non-compliant in both, leading to that 0%. Since implementing the majority of our process improvement in November and December 2024, we've hovered right around 70% compliance, which is great because 70% is my goal. But I always do say we need to strive for that 100% because our data is so volatile. You'll also see that a data point is missing for May, and that's because we only had 2 patients diagnosed with sepsis, and none of them met clinical criteria for severe sepsis or septic shock. So we have no data for May. Next slide, please. So what were my key takeaways from this whole process improvement? Well, we're still, of course, continuously working toward compliance. We only have 3/4 of data so far, so I expect our data and our progress to fluctuate a lot as we gather more cases for evaluation. Deferring to the experts, whether that be the physician, our phlebotomists, our nurses. It was only through talking to them that I was able to learn their processes, what works, what they'd like to change, or changes that they've already made in their clinical practice that I might not be aware of. They're the experts in the field, so it's always best to check in with them. Communication, especially interdepartmental communication, is key. I've not worked clinically at Scheurer Hospital in many years, so I try to round between departments to see how new processes involving SEP1 are working or what needs to be tweaked to fit their care model more appropriately. And finally, in most situations, we don't know what we don't know. Our clinical staff had basically no knowledge of SEP1 when I began this process improvement, so it was unrealistic to expect them to know what needed to change and the appropriate timeline for change. Bringing this to the forefront of our clinical staff's mind has put an emphasis on excellent sepsis care, and I look forward to continuing this improvement over my time here. And that is all I have.
All right.
Thank you very much.
Great. Thank you, Victoria. Okay, so we're moving into our discussion question answer time. I'm just going to check the chat really quick. If anybody has a question they want to go ahead and ask, you can go for it. Lots of compliments on your escape room idea. It sounds like there's a lot of interest there. Um, um, there is a question here from Julie. She says she also really likes the escape room idea. Could your EMR allow for bridge orders? Your ED docs could put in the orders and the admitting PCP sign off so that the orders aren't getting dropped.
So the bridging orders has been a suggestion in the past. I think that we are just pretty limited in our ability to do it. I know that before my time here, it had gotten brought up. So I think that we are just very limited as a facility on ability to use bridging orders.
Okay, awesome.
But I wish we could.
And then it looks like Jennifer Dyke asked what your handoff looks like, if you're able to speak to that.
So from my understanding, it is just a nurse-to-nurse report via phone call. There is communication with the patient's primary care provider prior to admission, and then they put in our admitting orders. but sometimes I think that what I've seen most frequently is that it's when our lactic is like 2.1 that the repeat lactic acid doesn't get drawn because yes, it's higher than 2, but it's not alarming and we've done we've given the fluids, the patient's improving, we're just admitting them. So then the admitting physician will usually add that order onto like routine lab work. When our ED physician might have put in a repeat lactic in the appropriate time frame. So that's kind of when that's getting missed. But yeah, our nurse handoff is just a phone call report.
Can I jump in with a follow-up question to Jennifer, actually? Are you asking the question because of like having a handoff checklist? I know that that's something I've heard that some folks are doing, and just curious if that's what you were looking for, if anybody on the call has a resource they want to share as far as that goes.
Yep, I was looking to see if they utilized a checklist in that handoff process.
Yeah, great.
So the idea, I believe, is to include something similar to that when we standardize our nursing handoff. I think that that will help eliminate some miscommunications.
And then Sandy Picard asked if Epic has the ability to flag what needs to be done.
Um, I am I am not able to speak on that, I guess. I don't know if Epic does have that ability. Um, it very well may. But I can't say for certain.
I think I saw Julia join the call from your
Yeah,
hospital. I don't know if Julia would be able to speak to that at all.
she might be able to.
Epic has different BPAs, so they don't call them BPAs anymore, but they have advisories that can populate to help trigger you. However, we do try to eliminate those just from a fatigue perspective. Overall, I'm not sure if that answers your question or not. You can also, put things in with Epic to help flag in the future in general, but as we're transitioning patients out of the ED, that also is impacted because of different credentialing process that we have as a rule. Bridging orders and everything is limited, so that also impacts our systems a little bit.
Looks like Jonathan has his hand raised. Jonathan?
Yep. Hi. First of all, thank you so much for the presentation. It was very, really insightful. My question, so from my personal experience at our institution, one thing that I think we struggle with is changing the culture or sorry, not culture, like perspective, people's perspective on sepsis. There's a lot of people who don't view sepsis as a medical emergency. So we can provide all the tools, all the education, all the standard work, but at the end of the day, if no one perceives it as a medical emergency, it's kind of all for naught. So I was wondering if you experienced something similar during your journey, or if this is something unique to us or unique to me.
So definitely not unique to you. We did face similar challenges here. I would say that in speaking with clinical staff, sepsis was always just kind of viewed as any other reason to come to the ER that, it didn't really take clinical priority. Um, in my experience, as an emergency department nurse, I know that people were always trying to change processes, and I was always frustrated because I thought processes were just changing for the sake of changing a process, and it didn't seem relevant to me. Even if you gave me like national statistics, statewide statistics, it didn't feel relevant. And so I'm not saying I was resistant to change, but I think I was less likely to change. Um, and that's primarily why I started tracking the length of stay, mortality, and readmissions, and then sharing that with clinical staff, because I think that it showed them when you see, wow, somebody was admitted to the hospital to an acute care unit for an average of 13 days when we weren't compliant with our care compared to 6 days when we were. I think that that is a very relevant statistic, especially because they're the staff that could have been caring for them. And then sharing, our sepsis readmissions. We did have one case where we were non-compliant the first time, and then there were 3 months of subsequent sepsis readmissions. And I feel like increasing that relevancy specific to your facility and your nursing staff may help with that a little bit. I have seen some changes here, and I know that when I was working bedside nursing, that would have helped me.
Awesome. Thank you.
And there was a question I missed earlier from Scott. He said, I may have missed it. What is the reflex timing on a repeat lactate if it is indicated?
So we currently don't have it set to reflex if we have a elevated lactic acid. That is in talks about how to effectively do that. We are talking with our innovation team and our ED leader to make sure that works and makes sense for their department. Other facilities that I've been at, it's been within 3 hours of that initial elevated lactic. So I think we're talking about something similar to that, but nothing in place right now. We were working on initially changing from the 2 separate order sets for sepsis just down to the one that had all the elements that we need.
I do have a question for the group, our participants. Just wondering if there are any other effective strategies for educating staff in sepsis compliance that your site has used, and if you'd be willing to share.
It may take folks a couple minutes to type that into the chat. So I think we saw Julie unmute though. I want to make sure if she had a question, she's able to ask that. Julie G.
I also have, until Julie speaks up, for some kind of reason, I can't see how to raise my hand here. But my name is Ramona, and I'm a quality specialist at Trenton for Scheurer Health East. And we provided education for inpatient nurses when we initiated inpatient code sepsis. We during a nursing week, when we celebrated nursing week, I performed Kahoot on sepsis on all the floors, all the units, engaged those nurses who are present. And the same during Sepsis Awareness Day. And we have sepsis champions, nursing champions, who we have educated, but I plan on meeting with them quarterly to discuss anything they might have, being brought to them by their colleagues, or any updates, any news. This is in works because we want to attract more nurses. So these are just a few things we've done here at Trenton. In regards to ED nurses, their management is very involved, and I don't know, they're just known they're effective, and they work with their physicians very closely, and they're the ones who can nudge the physician, hey, you need to order this, hey, they prompt them. So that's it.
Awesome. Thank you, Ramona. Okay. Anybody else have anything they'd want to share or any questions? Oh, got a comment in the chat here. Trinity Health, this is from Lisa. Trinity Health Livingston has a sepsis abstractor that is active in HMS. They have a big initiative right now with sepsis, with Michigan Medicine being a lead with the HMS initiative. And oh, yes, okay, with the HMS initiative. All right, awesome. So you guys are working closely with HMS on improving sepsis compliance, Lisa? Maybe you don't.
Sorry, I have to unmute.
That's okay.
Yes, that's one of the huge initiatives going right now. I am an abstractor for antimicrobial right now, but I know that they're doing a huge initiative with sepsis, and with their collaborative meetings, we get together and they talk about that with the influence of the ED and having a lot of guest speakers. So I don't know, just wanted to throw that out there too. Maybe Victoria knows about that or maybe not. I don't know. But for other people, and if you go to their website, which anybody can access, they do talk about the sepsis initiative.
Wonderful, thank you.
Just to help with collaborative, right? Because we're all
Yes.
working together.
Yeah.
That's right.
Before we get too far down the list here of all these wonderful comments, I did notice, in case anybody wasn't aware, that Rebecca shared that if you're using Epic, it can create a sepsis checklist in a sidebar, in case you weren't aware of that.
All right. Sounds like, or it seems like we're kind of winding down on our questions. Jessica, did you have anything you wanted to ask, or did you feel
I
good?
think we can move on to upcoming events.
All right, cool.
Thank you, Victoria.
Yes, thank you so much. All right, so MVC upcoming work groups. We have our next one on July 24th. It's a post-discharge follow-up work group. And this will feature discussion on a quality initiative to improve patient satisfaction with post-discharge planning. And this will be within a smaller acute care hospital setting. And that's with our University of Michigan Health Sparrow Carson site, I believe. And then following that one, our next work group will be pre-op testing on August 12th. And this presentation will focus on a MSQC project that one of our members was a part of for developing a new policy for pre-op testing orders and engaging surgeons on the different processes that go into that. If you missed any of the previous work groups, you will be able to read the highlights of those in our June blog, which should be coming out tomorrow. You should receive it in the newsletter, and it's also available on our website. And then the summary for today's work group will be coming out in early August. And then there will be a link here for you all, which will come through on the email to be able to register for future work groups, which occur between 12 and 1 o'clock virtually via Zoom. And then our upcoming events, we have a virtual networking event on August 21st. Registration is open for that. It will have a rural health critical access hospital focus, along with some MVC claims data, kind of integrated throughout. Final details on that will come out later this month. And then we will have our MVC Common Conditions push report coming in Q3. So keep your eyes open for that. And then just a reminder that MVC is still seeking presenters for our fall collaborative wide meeting, which is Friday, October 10th at Vista Tech in Livonia, Michigan. If you would like to submit a presentation proposal, you can do so through the link that'll be in the slides. I'll also put the link in the email that will be coming out. And that is it for our updates. Jessica's going to put our post-work group survey link in the chat for all of you participants. Just a reminder that if you are participating for the P4P program, you'll want to only select one hospital site for your post-work group survey to get the engagement points for. Thank you again, and everyone have a great rest of your day.